Okay, I am going to start on the third E&M video. We're going to start off with contributory factors, counseling coordination, nature presenting problem. Counseling's face-to-face, what they talk to the family, discuss the diagnosis test. The biggest thing in here is medical documentation for counseling. Coordination of care is you're setting up other care for the patient. Nature of presenting problem, the type of problem the patient presents to the physician. Types of presenting problems, we go through each area here. Minimal, self-limiting, low, without treatment, moderate, high, and then we go into the next one, which is time. Okay, so E&M code, let's just focus here. Every E&M code that you read through in this E&M section, most of them, unless they're age related, are going to say 2 key components, 3 key components, unless we are dealing with our office visits. Okay, with the office visits, again, they changed that where we're looking at just decision making and time. So let's go ahead and look at 99241. It is on my cheat sheet. So we have a problem-focused history, see that? Problem-focused exam, and then we have a straightforward medical decision making. So that is 99241. So it does state 10 minutes, so I will get that switched on your laminate. So with that, one thing to remember, let's just pretend that we have another office outpatient consult. Okay, so the patient comes into orthopedic and the doctor goes ahead and states that the patient had moderate decision making. They had comprehensive exam, but only a detailed history, right? So with that, since I need 3 of the 3, I can't upcode. So I can't go up to a 99244. I have 2 that meet 99244, but I need all 3 of them in that same column. So I have to give that patient a 99243 since I need 3 out of 3 key components. So you can never upcode. You're going to downcode, but you can't upcode. Okay, so with E&M codes, they're grouped by the type and place. So was it a consult? Was it an office visit? Hospital admission? We have those different ones on your E&M cheat sheet. One thing that is new to your CPT book as of January 1st, 2021, 99201 was deleted. I took it off the sheet itself. We also had 99202 through 99215, which I changed all the requirements for. They eliminated the history and physical exam portion. As long as it was appropriate, you can base these visits on medical decision making or time. So keep that in mind and make sure you reference to that. All right, so just what I said, it can be face-to-face or non-face-to-face. It's time spent with the patient, pre-visit, reviewing that chart. Just make sure that the physician documents well. Okay, so let's go to observation. Keep in mind that observation means outpatient. We have a couple of different areas of observation. The only one that I have here on the sheet is initial observation care. So they're not officially admitted to the hospital, so that makes them outpatient. They're not ill enough to be admitted, but they're too ill not to be monitored. So a good example would be somebody coming in for chest pain. They want to make sure they monitor them to make sure that it's not a myocardial infarction. So with observation, make sure these are not codes for inpatient service. Once again, they're outpatient. So we have an observation admission. It can only be reported the first day by the admitting physician. And these are the codes here. Make sure you review them in your book. Once again, you need 3 of 3. So if I have a high medical decision making, a detailed exam, and a detailed history, I cannot upcode to a 99220. I have to downcode to a 99218. So keep that in mind. When you need 3 out of 3, not upcode. So if one of my levels is at one of these low components, I'm going to have to go down there. To code higher, you have to have all 3 hit that high component. Okay, so when the patient's submitted with observation, status, and then discharge on the same day, there's different codes for that. These are 99234 and 99236. So go ahead and look at those in your CPT book. These here, as you can see, they need 3 out of 3 key components too. So let's just say that a patient was admitted at 1 a.m. into observation, and later on at 2 p.m., the doctor says we're going to discharge you from observation. So with the initial observation, it's $100. Okay, I'm just kind of throwing a number out there. And then for a patient to get discharged, it's, we'll say, $50. I know that's really cheap. So basically what these codes, they're combining a discharge code and the initial code together to put the component together. So it's going to have a higher relative weight, which these codes are going to cost a little bit more. And Medicare does have time constraints for these codes. So basically what you don't want to do is code an initial observation code and a discharge from observation code on the same day when one code can take care of everything. Okay, so if the patient was in hospital overnight for observation but less than 48 hours, the first day would be what we just had, the initial observation. The second day then would be an observation care discharge service, the 99217. There's no time component. Let me double check actually. There's no time component on the 99217. So if we have a patient that was in observation longer than 48 hours, so the first day would be the initial, second day subsequent observation care. And when you look at the subsequent, we'll talk about this in a little bit. So those are 99224 through 99226. And then the third day would be an observation care discharge. Okay, so go ahead and look at 99224, 99225, and 99226. The biggest thing here that you will see is that you only need 2 out of the 3 key components. The reason being is that a patient who had their initial, you need 3 out of 3 because they're probably going to do, that first time that patient's admitted, a pretty extensive history. So the next day when the doctor comes in, does a daily, I always relate subsequent as daily. So when the doctor comes in and does that daily, it's not going to be as a detailed history. So let's just pretend, let's go over to your initial observation care. And my patient came in, so if I guess let's not go here. Let's just look out of your book. So if I have a problem-focused history, which that's in the 99224 range, but I had a detailed exam and I had a decision-making of high complexity. I only need 2 out of 3 key components, so I'm able to code 99226. Okay, because I can have one of my components low. All right, so once again, I can code in 99226. Initial observation care, we did talk about that. That is right that we have here. Hospital inpatient, these are when a patient's admitted to the hospital. So those are going to be hospital care initial. That's going to be your history and physical. So with this, patient starting an observation and then admitted, the service is going to be bundled into initial hospital service. So if you start off with chest pain in observation and 5 hours later get admitted to the hospital, you're not going to code an initial observation and then code an initial hospital care. You're only going to code the initial hospital service. So these need 3 out of 3 key components. So the same thing with initial hospital care, I need 3 out of 3. So if one of these does not meet, so if I have a comprehensive history, comprehensive exam, but high decision making. So once again, if I have comprehensive exam or history exam, decision making high, I have to code a 99222 because my decision making wasn't at a high level. Okay, so types of physician status. Attending, primary admitting consultant is a physician whose opinion or advice is requested by another physician. We have types of care. And then we have 2 types of hospital inpatient services. So right here I have initial and subsequent. Once again, make sure you write down that subsequent is going to be pretty much your daily visits. Initial is going to be your history and physical the first time you get admitted. Initial hospital care, so your initial paperwork, plans, orders. You can only use this once for each admission. Subsequent is going to be only 2 out of 3 key components because a lot of times, like I stated before, you've already done the history, so you don't need to do the history for a subsequent visit. So 2 out of 3. So let's just kind of talk about this real quick and do an example. So if a patient came in and had an expanded problem focus, history, a detailed exam, and high decision making, I can code a 99233 because those 2, I only need 2 out of 3, meet the criteria for a 99233 because I don't need 3 out of 3. Even if my history was way down here and I had the exam and medical decision making up here, I can still code a 99233. Hospital discharge services, the final day of hospital stay when a patient was in the hospital for more than 1 day. And then you have that's the final status of the patient. So unique to that, only one physician can use a discharge code. You can't have two physicians discharge a patient. Only one physician can use this code, which is a 99238. Okay, so then we get into the consults. With the consults, they can be outpatient or inpatient, or outpatient or inpatient. So with the consult, with the office, that means outpatient. 3 out of 3, new or established, it doesn't matter. Down here is the new or the inpatient consult. New or established, 3 out of 3. Again, you have to be referred. So emergency department, this can be referred to as ER. These are by the emergency room staff. And you see here we need 3 out of 3 key components. Okay, I'm going to do one more video just to finish up talking about the E&M section.